Welcome to This Explainer. Today, we're diving into a really fascinating framework for understanding common electrolyte emergencies. Think about the human body for a second. It's essentially this incredibly intricate, beautifully balanced electrical machine, right? It just runs perfectly, humming along in the background, until suddenly it doesn't. And when this machine crashes, it's so often because microscopic ions circulating in our bloodstream have lost their delicate balance. Now, this isn't just some minor technical glitch. Disruptions to these microscopic electrical charges pose an immediate, life-threatening crisis in an emergency setting. Seriously, when the chemical gradients fail, the very cells that power our heartbeat, our brain waves, and our muscle movements literally start to misfire. It is an absolute high-stakes emergency. Okay, let's dive into our roadmap for today. We'll start with the body's electrical machine. Then, potassium, the heart's pacemaker. Next is sodium, the brain's balancer. After that, calcium, the muscle stabilizer. Then we'll cover magnesium, the unsung hero. And finally, we'll wrap up with the treatment tightrope.
Section 1. The body's electrical machine.
To truly grasp the danger of electrolyte imbalances, we really have to understand the baseline homeostasis required for normal cellular function. And honestly, it all comes down to membrane polarization. Think of this as the delicate electrical gradient maintained between the inside of our cells and the extracellular fluid. It's fiercely guarded by ion pumps like calcium ATPase and sodium calcium exchangers. The crucial takeaway here is that clinical manifestations, whether we're talking about cardiac arrhythmias or neurological seizures, fundamentally result from disordered membrane polarization. Once that gradient is lost, chaos just ensues.
Section 2. Potassium, the heart's pacemaker.
That brings us to what is perhaps the most immediate threat to life, potassium. We can basically think of potassium as the heart's pacemaker, so its effect on rhythm is profound. When it goes out of range, hyperkalemia completely degrades the heart's electrical signal. As potassium levels rise from 6.5 milliequivalents per liter, we initially see tall, peaked T waves. Then, as it climbs past 7.5, the P wave flattens out and the QRS complex begins to widen. If potassium exceeds 10, the QRS degrades entirely into a deadly sinusoidal pattern. If you're seeing these changes, hyperkalemia needs to be suspected and treated immediately, even before those lab results come back. Because this is so incredibly lethal, there is a strict 3-step protocol for treating hyperkalemia. Step 1 is immediate membrane stabilization using intravenous calcium, like calcium gluconate or calcium chloride, which essentially buys you time. Step 2 is shifting that excess potassium back inside the cells, using agents like sodium bicarbonate, nebulized albuterol, or a combination of insulin and glucose. And then step 3 is the actual removal or excretion of potassium from the body. That's achieved through diuretics like furosemide, or in really severe cases, hemodialysis. But listen, potassium dropping too low, hypokalemia, which is defined as a level below 3.5, is also incredibly dangerous. Contrast those peaked T waves of hyperkalemia we just talked about with what happens here. Hypokalemia literally flattens the T wave and produces a characteristic prominent U wave right at the tail end of it. You'll also see dangerous QTC prolongation. All of this can perfectly set the stage for deadly tachyarrhythmias.
So how do you figure out exactly why a patient's potassium is low in the first place? Well, measuring a spot urine potassium acts as a fantastic clinical detective tool. If you see a spot urine potassium greater than 20, it suggests the kidneys are inappropriately losing potassium, which points to renal loss or issues like hyperaldosteronism. But if it's less than 10, the kidneys are holding on appropriately. That means the loss is extrarenal, so you'd start thinking about massive GI loss, profound sweating, or transcellular shift.
Section 3. Sodium, the brain's balancer. The primary danger with sodium isn't just the chemical imbalance itself, it's the dramatic water shifts that happen inside the brain as a result. To manage these shifts, we mathematically categorize hyponatremia based on extracellular fluid volume status. For instance, hypovolemic, like those with heart failure or cirrhosis, typically have a low urine sodium, usually less than 10 in decompensated states, because the body is desperately trying to hold on to fluid. Extrarenal hypovolemic patients, like those with severe vomiting, also have low urine sodium. Meanwhile, renal hypovolemic patients, losing salt through diuretics, will typically have a urine sodium greater than 20. What's truly fascinating is the physical mechanism of how our brain adapts to all this. If hyponatremia is acute, brain cells swell. But after about 48 hours of sustained hyponatremia, the brain adapts. It extrudes organic osmolytes to return the cell volume to normal. Now here's the catch. If you rush in and correct the serum sodium too rapidly, you strip water right back out of those adapted cells. This causes massive cell shrinking, leading to osmotic demyelination syndrome. That is a devastating complication that can cause quadriplegia, seizures, and even coma. Because of that terrifying risk, knowing your limits is an absolute lifeline. For chronic hyponatremia, your maximum correction rate should never, ever exceed 6 milliequivalents per 24 hours in high-risk patients. For low-risk patients, there is an absolute cap of 12 milliequivalents per 24 hours. Curing the patient too quickly in this scenario literally causes permanent brain damage. On the flip side, hypernatremia is often driven by diabetes insipidus, or DI, which is where the kidney simply can't reabsorb free water. It's crucial to understand the difference between the two main types here. Central DI stems from an abnormality in the hypothalamus or pituitary gland, and it responds beautifully to treatment with desmopressin. Nephrogenic DI, however, is a localized issue with the kidney itself. It's often a mutation or acquired from drugs like lithium. Because the kidneys won't respond to external hormones, this type actually requires a low-salt diet and adequate hydration.
Section 4. Calcium, the muscle stabilizer.
Let's transition over to calcium, which acts as the ultimate guardian of our muscles and nerves. When calcium levels drop below 2.0 milliequivalents per liter, it triggers extreme neuronal excitability. In cases of severe hypocalcemia, the heart's electrical trace will show a very long QTC interval along with T-wave abnormalities that actually actively mimic ischemia. When you're stepping in to treat this with IV calcium, there is a critical word of warning. You have got to use IV calcium cautiously if the patient is on digitalis. Hypercalcemia can severely potentiate digitalis toxicity, making a bad situation much worse. Physically, as serum calcium falls, neuronal membranes become increasingly permeable to sodium, which massively enhances excitation. This results in intense, undeniable physical symptoms that you can literally see right at the bedside. We're talking neuromuscular seizures, the classic facial twitching known as the Chvostek sign, carpopedal spasms called the Trousseau sign, and even circumoral paresthesias, which is that concerning tingling right around the mouth.
Section 5. Magnesium, the unsung hero.
Next up, we turn to magnesium. This is really the unsung hero of our cellular machinery. It's an often overlooked intracellular ion, but it is intricately linked to the homeostasis of both potassium and calcium. Identifying a magnesium deficit means you have to look at several non-renal pathways. You might see redistribution issues during refeeding after starvation or an acute pancreatitis. Extrarenal losses can happen through profuse sweating, severe burns, or severe diarrhea. And of course, decreased intake is heavily tied to things like alcoholism, malnutrition, or malabsorption syndromes. Now, let's factor the kidneys into the equation. Renal losses can definitely happen from osmotic diuresis or ketoacidosis. But here's a pro tip. Pay very close attention to the patient's drug list. Medications like loop diuretics, aminoglycosides, and proton pump inhibitors routinely drain the body of this crucial ion. Additionally, endocrine disorders like SIADH and hyperthyroidism play a massive role in magnesium depletion as well.
Section 6. The treatment tightrope.
This brings us to the climax of our explainer. Treating these abnormalities is never just about fixing one single number on a lab chart. It is a delicate, completely interconnected balancing act. It's a true treatment tightrope. And here is a massive clinical pearl you absolutely must take away from this. You often simply cannot fix potassium or calcium abnormalities without first addressing a magnesium deficit. Hypomagnesemia has to be corrected to optimize potassium reuptake in the body. And remarkably enough, symptomatic hypocalcemia typically doesn't even develop until magnesium falls below 1.2 milligrams per deciliter. They are entirely linked. Because this tightrope is so precarious, clinical protocols have high stakes do not cross hard numbers. When you're giving IV potassium, the maximum is generally 40 milliequivalents diluted in 500 milliliters of normal saline given over 4 to 6 hours. For severe, highly symptomatic hyponatremia, like if a patient is actively seizing, you use 100 to 150 milliliters of 3% hypertonic saline to acutely raise that sodium level. And for life-threatening conditions like torsades de pointe or eclampsia, you push 1 to 4 grams of magnesium sulfate IV over 10 to 60 minutes. It's strict math, but it's absolutely required to safely navigate these emergencies. We've seen how calcium stabilizes, potassium paces, sodium balances, and magnesium ties the whole shebang together. But knowing the numbers is only half the battle. The clinical presentation always dictates the urgency, so I'll leave you with a provocative thought. As you manage these microscopic electrical charges in your own high-stakes emergency scenarios, which of these 4 ions, potassium, sodium, calcium, or magnesium, poses the most unpredictable tightrope walk in your daily clinical practice? Reflect on your absolute toughest cases and let that guide your continuous learning. Thanks so much for joining me on this explainer. Keep those